I invite Gary. So I think Dr. Rupesh will introduce Gary.
Thanks, Professor Natarajan. And we'll now move from to North America. And we have my dear friend Gary from US, and he represents the US Army, and where I was introduced to him through Grant Justine and my dear friend Marcus Collier. He's working currently at Brooke Army Medical Center, San Antonio, Texas, USA. And very interestingly, he's a residency program director, and that's what we want to hear from him for the SOSTEC ophthalmology. And he's also the president of Society of Military Ophthalmologists, and he's assistant professor at Uniformed Services University. Most importantly, he's a refractive surgeon, but with a lot of passion and a lot of interest in trauma management and particularly teaching the residents. To present to you is Gary. Gary, over to you.
Thank you so much. It's an honor to be here, and I thank you guys for your time and letting me speak to you today. So we've talked a lot about different challenges out there, and I just want to emphasize on how to teach people. How do we get through these challenges? And my job is to help our residents. So we're going to talk about resident training in ophthalmic trauma and how do we overcome these challenges in this current era. So thank you very much for your time. These are my views and not those of the Department of the Defense or the Army or the US government. I have no financial disclosures, neither does my spouse. So first of all, thank you for teaching residents. It can be a thankless job at times, but it is very rewarding. So for all those that teach, thank you. I think most of the group, you guys are all professors. Thank you for teaching and taking that time to teach. So just a little bit about my program here in San Antonio, Texas. We're a city of about 2.3 million people. We take care of about half the city's trauma. We're the only level 1 trauma center in the Department of Defense. And so we are here to take care of the trauma of civilians. Even though we're a military place, we take care of a lot of the civilians. So I have 18 residents. I have 20 faculty that all cover trauma and have to be ready to deploy across the world to cover trauma where needed. We also train residents from other residency programs in trauma that are in military programs. And then we train our staff ophthalmologists have to be ready to manage trauma as well. So when someone is called up to deploy somewhere else, they'll often come to our facility to prepare so that they are comfortable with trauma. So if you've seen the news, you've seen lots of challenges in our country. We're not going to focus on these challenges, but let's focus on the challenges of how do we train people. All right. So one of the biggest challenges is finding time. How do we make that time? A lot of our universities and facilities want you out of the op at a certain time. There's a push to get through a number of cases. And so a lot of the ocular trauma cases take a long time. And when you're training, it takes even longer. So how do you make that available for the residents to give them that time to learn? Also in their schedules are very busy. So how do I create time for them to learn, to practice on the simulators, to practice throwing sutures? It can be challenging because we have so many priorities in life. So just to focus on the time so that you learn ophthalmic trauma. Another challenge a little bit is having patience. Sometimes it's so much easier just to take over and perform the surgery yourself. How often have you watched someone throw a suture and then you just have to cut it out and throw a new suture? I just think back of when I was a resident and my staff let me take time to throw the suture and then they took it out and fixed it, but they were patient with me. So sometimes it's tough when teaching sometimes, but you have to have patience. Everyone learns at different levels. Some people faster than others as they learn. Another challenge is having the experts. How are you keeping up with your skills to teach? We all don't have Dr. Kuhn in our program. In the military, a lot of us spend a few years in the military and then move on to civilian programs. And so we have a hard time keeping some of the senior experts. I remember 6 months out of my training, I was told I was one of the senior cornea guys. And so it was definitely a challenge to step up and be ready, but to have the expertise. Also during our training, during some of our fellowships, we don't throw as many sutures as we used to. A lot of our surgeries are sutureless. So when it comes to ophthalmic trauma, how are your suturing skills? How do we make sure we have that expertise? Then there's the case volume. You got to have the cases. If you want to be good at something, you have to practice. And so in the US, our residency is 3 years, and all you have to get for the globe trauma minimum is 4 cases. So are you the expert after 4 cases of fixing an open globe? Obviously not. You definitely need more practice, but that's what the requirement is from the ACGME. Now, on average, most programs, national average in the US based on last year's study of results was 9 open globes. So most residents graduate with 9 open globes. Our program, it was 9.5. We had the lowest resident had 5 and the highest had 17. So we have to figure out ways where we continue to get the case volume. I think in other countries, you have a lot more cases than us. And especially as we advocate to prevent ocular trauma, we're decreasing our business in the operating room, which is okay, but we still have to keep our skills up. Then we are also limited here in the US by our duty hours. Our residents can only work so many hours, 80-hour work weeks. We need to give them 8 hours between the shifts at times. So trying to manage their fatigue to keep them motivated and keep them going with their cases. So work hours can be a limit. And then funding. I'm a refractive surgeon, and refractive surgery, we can always find funding. Industry is very supportive. But when it comes to ocular trauma, it can be a challenge to get funding. Funding to help with training, to help with the patient care. But you want to have funding for these resources and these courses. I'll talk to you about a course that we hold. And we have to get funding to send our residents to these courses. So it can be a challenge to get funding to help with ocular trauma. And I've heard that from other countries as well here. And then staying motivated, motivation to take care of ocular trauma. You guys are all motivated. You motivate me to continue with ocular trauma, but not everyone's excited about ocular trauma. These patients come in after hours. You're up late. They can be very challenging cases. It's not the easy 5-minute phaco. You may spend hours, and these patients need some extra help. So how do you stay motivated to care for these challenging patients? And so it can be a challenge with our residents. About halfway through the year, after they've seen their 200th orbital fracture, they're not too excited to go see another one. But we continue to try to motivate them and keep them engaged. All right, and then with ophthalmic trauma, we have some unique challenges. We have this patient population that's sometimes not always the most compliant. Here in the US is often sometimes uninsured. We may not get reimbursed. Be a little bit more challenging when they're coming in after hours. Again, supervision can be a challenge as we teach ophthalmic trauma because it's after hours. So our first years are always seeing the trauma. Their seniors are available for backup. For our first 3 months of residency, we require the seniors to come in. But how often is the staff coming in to supervise? The staff come in for every surgery in our program, which is nice. But sometimes the residents try to do things on their own or don't call when they need help. So we're always working on supervision. Every trauma can be unique, and so they're very unique cases. So how do you give an algorithm in trauma? We're working on checklists and ways to do that, but how do we guide them through trauma? We just need to teach them the basic principles, but each case is going to be unique. And then safety, protecting our residents. One of the safety issues we've had is that we didn't have an ophthalmology room in the ER, and so they'd always want to come to our clinic, which is a long ways away from the ER in our hospital. And at night, the residents by themselves with the patient has a seizure or they need help or they feel uncomfortable around the patient. There was little, and so we've had to create a room in the ER itself to allow them to see these patients, although it doesn't have all their equipment and imaging systems. So sometimes their exams can be limited. And then one of the big things with trauma is the transition in care. And so you stay up all night, take care of these patients. How do you pass it off to your colleagues the next day? How do you make sure things aren't missed? And so we've been very fortunate with COVID. We've created a virtual sign out. So every morning at 6:45, our residents log in virtually through Microsoft Teams. And in the past, the residents all did a lot of this on their own, but now the staff is able to virtually log in and listen into it. So it really helps having the staff there at the sign out every day. And so we can kind of keep up, make sure we're not missing anything as we work together as a team to help with ophthalmic trauma. So to make sure that residents know what they're doing, they have to be able to perceive they're comfortable, and we definitely need objective ways to see how they're doing. One of the subjective ways we wanted to check, and Dr. Loretta at Wilmer and her team, they surveyed all the ophthalmology residents in the US. They got 118 responses to see what kind of made them feel comfortable or prepared for ophthalmic trauma. And hands down, it was the supervised and independent lab practice on animal or synthetic eyes. So it's really just getting that practice, supervised or independent. They just need to be working on the simulated eyes and the animal models to get better. Now, obviously, if they're doing cases, That's even the best way to do it, but our case volume is limited. So how do we teach ophthalmic trauma? And these are a few things that we continue to work with our residency to teach. There's lots of resources out there, but we need to get better with our texts, our videos, our online modules. We'll talk about some meetings we've had, simulation, and then I'm going to talk about our ocular trauma course. Is one of the things we're proud of in the military that we've been put on for over 10 years that really helps kind of teach the fundamentals of ophthalmic trauma, and then partnering with some of our trauma centers. So resources, texts, and videos. Dr. Kuhn's got a few books out there. These are expensive to purchase for every resident. We do try to get one for the program, but trying to put out videos are extremely helpful nowadays. When you're learning cataracts, everyone goes to the cataract coach and watches videos. We want to create that with trauma videos, and AAO has it with some of their online OneNet videos, a really good one for Open Globe. But we hope with ASOT, our American Society of Ophthalmic Trauma, to continue to create videos, and I appreciate hearing all the efforts the different organizations across the world have done. Those videos, I think, make a huge difference to see your techniques and watch, and then continue just to create online modules. We had our meetings with COVID. It's better to meet in person, and we learned so much getting together. We create those relationships and we can create ideas, but that went away with COVID. We were fortunate to work with APOTS and the ASOT, and we came together and created this opportunity for residents to present the research and have discussion. And it was amazing, the research that was presented back in June. We had over 150 abstracts submitted to my email, and it was hard to pick the top ones for this, but it was amazing to see the interest. And so it's great to continue to see the resident research, and we just have to be able to get together to share our lessons and work together. And then the big thing is simulation. We need to figure out ways to simulate ophthalmic trauma to prepare our skills before we're actually operating on a patient. So many residency programs have created kind of rooms for simulation, and this is kind of our efforts. We've done that with at our facility. I've been to various facilities. I visited Iowa and Nebraska. They're getting grants from patients and working on simulation areas. And then they put time in the residency schedule for the residents to work with the staff to work on this simulator. Now, most of it's based on cataract surgery when you look at these centers, but we need to work on getting better models for trauma. How do we incorporate those into our simulate centers? And it does all cost money, so funding can be an issue. How do you allocate the instruments and purchase the models can be a challenge. But simulation, what's out there? A lot of this, again, is based on cataracts, but how do we modify it so that it can help with ocular trauma? Some of the models that we have at the Boynico, it's very reasonable fidelity, and it's somewhat cost effective, but it is interesting. We've used this for kind of corneal lacerations, scleral lacerations. You can get ones with the muscle, and you can disinsert and reattach the muscles, the ocular muscles. So some of these models are very helpful as we practice and teach the techniques and just walk them through it before their surgery. The Cataro kits are good for cataract surgery, but and glaucoma a little bit, but need to modify it a little bit more for trauma, and it's a little bit more challenging. Most of the residencies in the US have the IC simulator. We require a lot of modules to be completed prior to cataract surgery, but for trauma, it lacks some of the trauma benefits. But if you learn to be a good intraocular surgery and learn those basic techniques, work on avoiding any kind of tremors and just moving around in the eye, that will prepare you for some ophthalmic trauma. And so being on this simulator, we've noticed a huge improvement if the residents spend hours on the simulator, which we've had them do during COVID when they had downtime to prepare for being back in the operating room. And then one of the simulators, I don't think it's on the market yet, but we worked on at our trauma lab, was the Ocular and Cranial Trauma Treatment Training System. And it's a nice model that actually gives you a score and evaluates you. It's a little nerve-wracking because you're compared to the residents and staff, but on the computer, it looks at your movements, it looks at your suture passes as you go through this tissue. It's not perfect to human tissue. It is pretty good texture. And so this is one of the example of a module that we could use in the future. Another one, lateral canthotomy, cantholysis, very important with orbital compartment syndrome. We use this to try to teach our trauma surgeons, our ER docs, but also our residents to make sure they know the steps so they're ready to perform their lateral canthotomy, cantholysis. The big thing that we've had for over 10 years, and we do this in Bethesda, Maryland every May, except for last year, we missed it in 2020 due to COVID, canceling everything, but is our TriService Ocular Trauma Surgery Lab. And we put this on, and it's just to teach the fundamentals of trauma. And what it is it's a 4-day course where we work with residents and faculty to go over the basics and fundamentals, but also give them practice on our animal models that we bring in. We have lectures, many lectures about trauma and the different techniques, teaching the fundamentals. And then we have wet labs throughout the week. We used to do all the lectures first and then switch to wet labs, but we've now had it where we kind of give some lectures, mix in the wet labs. And it's a lot of one-on-one, almost 2-on-1 training with our residents. In 2018, we had 36 residents and 60 faculty. So the faculty kind of wander around, making sure we're one-on-one as the residents learn each suture technique. We walk them through the basics of just a single interrupted versus various techniques with the sutures. And so we work closely and monitor them as they go through that course. And so this has been huge. We try to send our staff before they deploy too. And we've now made it an Army requirement to go to this course for ophthalmologists. Within 3 years, they need to spend the week at this course just so that they keep up with their trauma. Other things we're working on is trying to partner with civilian institutes that have trauma centers. The Army general surgeons have kind of trained in the past, or they have a spot at the University of Miami. And so they go there and that's their assignment. They're paid by the Army, but they work for the University of Miami. And so we're looking at other civilian military partnerships right now, and Vanderbilt is one of them. But we're basically free labor. You guys have us for free. The Army pays our salary. And our benefit is we get to perform surgery and improve our skills and share our techniques. Now, COVID has caused some challenges. We've heard that from everybody. And so we're probably tired of it. But things that affects our training is our faculty and residents are tasked to do other duties. And this is across the US. The Columbia residents were on the wards helping out with kind of duties. Our residents have been fortunate and protected, but our faculty have been pulled to run the COVID tent, screening tent, testing people. Next month, I'll be spending a week giving out vaccines. And so my job is to take care of those with the vaccines. And so it takes you away from teaching the residents. We have to do what we can to help out. Bed space is a problem. Our trauma patients often need to be put in the overnight. We watch them. Sometimes it's social admits, meaning they have nowhere to go and we just need to watch them. But now with COVID, we're trying to get the patients out the door and our beds are full here in San Antonio. We're struggling with that right now. And then COVID patients, as we talked about, using the proper PPE, protecting our residents and staff. At times they're scared to kind of come in and see those patients. And so we have to make them feel safe to want to see these patients, and we have to teach them the proper way to use their protective gear. One of the things we used in the beginning, Columbia created this and put this on iWiki, is the triage guidelines, trying to help the residents of what they need to see immediately and what maybe can wait. But the biggest thing is to talk to their staff and see what they can do. Obviously, with ophthalmic trauma, it's more urgent and they should be seeing those patients. Another protocol, we've been trying to create protocols to help the residents so they're not up all night. So this is the San Antonio orbital fracture algorithm we call SOFA, to kind of help them guide through their training. So you can see that here, and we verified that this algorithm caught all of we didn't miss any vision loss due to it. We tested it out, but it shows some signs of when they should see their orbital fractures. And then teleophthalmology, I think that's the key of the future for some of this trauma. It's important in the military. We have a grant, we have called the Foxtrot app that we use for virtual ophthalmology. And we want to incorporate this into our training. So we really want the residents to start using this. Our goal right now is the ER to consult the resident virtually through teleophthalmology, and then the patient come back in the morning and we verify if anything was missed to see what we can and perform over teleophthalmology. So just in summary, skills can atrophy after residency, so we still have to continue to learn and train. Some people have lack of interest as they're in private practice and they don't want to be up all night, but you guys can make a difference. You do make a difference. So please continue to serve as a role model. Dr. Mazzoli is one of mine with ophthalmic trauma and one of our heroes. And continue to produce ophthalmic trauma teaching materials, videos, training modules, simulators. Continue to support APOTS and ASOT. We started the American Society of Ophthalmic Trauma, and we hope to continue to grow just so that we can educate others and make a difference. So again, stay motivated. This is our residents. To stay motivated, they created a half marathon, and many of them were doing the half marathon for the first time back in November. But it was something for them to train for, something for them to do during these challenging times. So thank you again for everyone and your time.
Thank you very much, Gary. I'm so happy that Dr. Bob Mazzoli and Marcus Collier introduced you to us. And it seems like you accomplished a lot, and we have a lot to learn from. And I think this global collaboration is now going to flatten the world, and hopefully we will all learn from each other and come up with a structured course.